गुड आफ्टरनून सर. सर एकदा अनम्यूट करता का? तुमचा माईक एकदा अनम्यूट करा, आपण चेक करूया. सर माझा आवाज येतोय तुम्हाला? अनम्यूट करा सर. हॅलो राऊत सर, तुमचा आवाज नाही येते मला.
आता येतो आवाज?
येतोय. एकदा खाली तिथे खाली एक ना स्क्रीनवरती शेअर स्क्रीनचा ऑप्शन आहे, तिथून तुम्ही तुमची पीपीटी आधीच ओपन करून ठेवा आणि मग आपण
एकच मिनिट पण कॅमेरा बंद होईल का तेवढं?
नाही लगेच आपल्याला सुरू करण्याची गरज नाही, फक्त तो एक ऑप्शन आहे आपल्याला की तिथून आपण स्लाइड्स
होतं का? पीपीटी शेअर होते का? झाले का? चालू ठेव ना, आवाज पण चालू ठेव. होतंय?
हा होतंय सर. ओके चालेल.
ओके, थँक्यू. आवाज क्लिअर आहे का? पण
आवाज पण क्लिअर आहे आणि
ओके
आता फक्त की आता परत जेव्हा तुम्ही नेक्स्ट टाइम परत शेअर करणार त्यावेळेस म्हणजे ती डायरेक्ट सुरू नाही होणार नाही, तर परत एकदा तुम्हाला शेअर करावं लागेल.
बंद करून चालू करावं लागेल. ओके,
एकदा तो शेअर स्क्रीनचा ऑप्शन आहे तो परत एकदा घ्यावा लागेल.
ओके ठीक आहे, चालेल. थँक्यू. ओके
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 एक 5 मिनिटात करूयात आपण.
हो चालेल. एवढं लांब काय लाईटची? इथली लाईट चेहऱ्यावर लाईट पाहिजे ना, काहीतरी गडबड झाली. ही लाईट छान नाही. कॅमेरा आपल्याला स्क्रीन दाखवतो ना, कॅमेरा नाही दिसणार. नाही नाही आता मी दिसत नाही पूर्ण. बघ बरं. मग नाही आपण ज्यावेळी स्लाइड केलं बंद करणार नाही. स्क्रीन पूर्ण वाचता आली पाहिजे ना, मेरे वाचता हे करणार बंद करणार. तू आता कॅमेरा बंद कर. नाही काय बंद आहे का ना? मी ज्यावेळी क्लिअर कुठं दिसणार? असं दिसणार ना समोर. खाली गेला तो नाही उशीर केलं.
Recording.
Speak, mother, speak.
So good afternoon and welcome to all.
सुरू केलं.
It is my humble request to all, please keep your mic mute. And if you have any query, then you can write in chat box, or we will discuss later in the last few minutes of this session. So please keep your mic mute and write in chat box. Okay. Then so So again, welcome to all on behalf of Ayush Department of Maharashtra University of Health Sciences, Nashik. We are gathered here for online clinical meeting, and today's topic is, as we know, management of vasculotoxic snake bite. And for that, we have expert faculty, Dr. Sadananda Rao. He is a dedicated person to medical and social services, serving to patients from rural and tribal areas since more than 35 years. He is the founder president of NGO Vignahar Medical Foundation, Narayangaon. He is attached with many NGOs and many medical institutes and many medical hospitals actually. He has initiated Zero Snake Bite Death Project since 2005 and treated more than 6,000 snake bite cases with zero mortality, zero morbidity, and minimum kidney damage. So, and he is awarded with many precious awards like वंदनीय बाळासाहेब ठाकरे आरोग्य रत्न पुरस्कार 2023, then Lokmat Dhanvantari Puraskar, and much more. So welcome, sir. You can share your
Thank
slides.
you.
Yes, sir.
Thank you, madam. Can I start?
Yes, sir.
Can you hear me?
Yes, sir.
Okay.
You're audible. You can share
Okay.
your slides again by
Thank
clicking
you.
green tab. Okay, sir.
Thank you for organizing a lecture on this very important and most neglected tropical disease of the snake bite. As all of you are aware that snake bite is a very neglected disease of the farmers, and it is a major accident in the farmers, very life-threatening and needs a very time-limiting emergency. So, as we all know that living snakes are found all over the world, on every continent except few countries like New Zealand, Ireland, and some parts of Atlantic and Central Pacific. India is the dense and dark forest of India. These are the best habitat for the reptiles. This forest offers a wide range of home for the giant snake and their prey. So snake bite incidents all over the world, there are around 50 to 60 lakh snake bite occurs every yearly. Out of that, 20 lakh people get envenomation and 80,000 to 1,38,000 deaths occur annually due to snake bite. More than 4 lakh people are left permanently disabled, means they need either amputations or they develop acute renal failure, stroke, and other complications. In India, annually there are 20 to 25 lakh snake bites, and around 12 lakh people are died due to snake bite from 2000 to 2019. Means annually there are around 64,000 deaths. This is the latest national mortality survey. 80% of the global deaths due to snake bite occur in India. In most of the states like MP, Odisha, UP, Bihar, Jharkhand, Rajasthan, Gujarat, Andhra Pradesh, Bangladesh, Pashchim Bengal, there are snake bite cases. Approximately, there is a one snake bite death for every two HIV/AIDS deaths. That the ratio is 2:1. According to WHO, only 10% of the snake bite cases are recorded. You can easily imagine how severe is the problem. WHO has added snake bite in most neglected tropical diseases in 2017. So there are many venomous snakes in India. All over the world, there are around more than 3,000 species of the snakes. In India, there are 275 species, 71 genera, 11 families, 62 species are venomous, and 42 species are mildly venomous. 171 are non-venomous. So this is the snake bite is the highest burden in rural areas of the developing world. These factors are climate change, seasonal, there is increase in the incidence of the snake bite in rains and harvest, agriculture workers, fishermen, epidemics resulting from flooding and invasion of environment. In example, in Kerala, Kolhapur and Sangli floods, there is increase of incidence of the snake bite. See, this is the major occupational hazard in the farmers. In Pune district, there are major 4 dams, and land cultivation is increased, and the incidence of the snake bite is also increased. See, this is a sea snake and fishermen. Snake bite is more common in snake charmers and dancers. So this is the map of the Pune district. You can see this red zone, that is Junnar and Ambegaon region. There is increased incidence of snake bite due to increased cultivation of land. How to differentiate between venomous and non-venomous snakes is also important part. In venomous snakes, fangs are hollow like hypodermic injection needles. Teeth are two and long fangs. Pupils are elliptical. Tail is much compressed. In non-venomous snakes, fangs are several small teeth. Pupils are round. Tail is short and solid and not much compressed. So it is very important for the differentiation of the snake bite, venomous or non-venomous snakes. Out of total snakes, 46% of the venomous snakes are in Indian belongs to the viperine group. That is Russell's viper, Swastika viper, green pit viper, and bamboo pit viper. And 54% are elapids. That means cobras, krait, and coral snakes. Bioactivity, you can see there is neurotoxicity, myotoxicity, platelet aggregation or inhibition, anticoagulant effects, microbial side effects, inflammatory, hypotensive, hemolytic, and cytotoxic. Same slide again. Now we are going to see our topic, Russell's viper. You can see the different Russell's viper and different colors in Madhya Pradesh, Maharashtra, Junnar in Pune district, Maharashtra, and West Bengal. See the color differentiation. Mostly it is called as Honus in our part, Maharashtra. Maximum length is 180 centimeters, and it is easily identified. It is very stout, round body with thin, short tail, flat, triangular head with the small scales on the top, large nostrils, vertical pupils, brown body with 3 rows of dark brown oval-shaped marks. So it is very beautiful animal. You can identify it very easily. Shaped marks that have a white border, dark black spots between marks, and underside and lip scales white. So you can see this Russell's venomous apparatus, and fangs are very large. You can see venomous gland and the duct. Now we'll go to the signs and symptoms after Russell Swiper bite. There is very severe pain at the site of bite. Tenderness and swelling is very rapidly progressive. It goes from one joint to another and spreads all over the body within a day or two. There is severe local pain. Local bleeding starts immediately after the bite. There is nausea, vomiting, and pain in abdomen. Systemic bleeding like hematemesis, hematuria, subconjunctival hemorrhage, intracranial, intraabdominal bleeding, PTC, purpura, ecchymosis, and rarely intracranial bleeding also. There is acute kidney failure due to severe local enaming and sepsis. The severity of the signs and symptoms depends on the age of the victim and the size of the victim. There is severe local enaming, bleeding and coagulopathy, shock, severe hypotension, collapse, and death may occur immediately after the bite. There is paralysis plus rhabdomyolysis plus renal failure in Western Russell Swiper, permeability syndrome plus pituitary infarction. And now we'll discuss some cases of the Russell Swiper bite. This is a 14 years girl with a history of Russell Swiper bite, foot near the foot, and she was admitted 12 hours after the bite without any anti-snake venom. So she was presented very late to our hospital. She developed acute renal failure. We have managed her with only fluid and electrolyte correction, severe local necrosis. Her tendo achilles was totally necrosed. There is debridement required twice. We had given her back therapy, skin grafting. Then there is flap cover of tendo achilles done, and she required 5 surgeries and almost treatment for 5 to 6 months. So it is a very complicated and delayed presentation. So these complications occur. This is 35 years female with history of Russell Swiper bite. You can see left foot near the ankle joint. She was admitted in shock. She was breathless at the time of admission. Bite marks are seen oozing. There is swelling up to thigh, extended up to the anterior abdominal wall and chest. There is ecchymosis. She required 2 blood transfusions. We had given her 30 vials of anti-snake venom, IV antibiotics, necrosis. There is extended up to mid-leg. Debridement done twice. She required skin grafting. And snake was brought killed after a few days from the same spot. You can see unusual site of Russell Swiper bite. This man, 45 years male, was feeding the cattle with the hand, and the snake bitten on the left side of the nipple. There is severe pain, swelling, erythema, and hypotension. She developed severe local necrosis after the bite. This 8 years boy with Russell Swiper bite, he was admitted in severe shock. There is tachycardia pulse more than 180 per minute, PP less than 70, and he developed swelling blisters all over the body, limbs, genitals, and there is anuria. This 40 years female with history of unknown bite. We diagnose her as a case of Russell Swiper bite due to severe signs and symptoms and uncoagulable blood for more than 20 minutes. She developed non-oliguric renal failure, means her urea and creatinine are raised, but her urine output was normal. But we have treated her only with the hydration therapy, antibiotics, anti-snake venom. But she needed amputation of the index finger. You can see her blood urea is 156, creatinine raised up to 7.7. Electrolytes are also deranged. This 10 years boy had a Russell Swiper bite. And we were swelling up to the limb. This is also a case of Russell Swiper bite, 40 years male, on the both hands. He was cutting the grass and reflexly another hand also moved. So there is a bite on the another hand also. And there is severe burning pain with rapidly progressive swelling of the hands. WBCT clotted in 20 minutes, but he had a severe hypotension. He was drowsy at the time of admission, breathless. We had given him 30 vials of anti-snake venom. Debridement is required. WBC count is also raised. This 24 years male with a history of snake bite while driving tractor. The snake came on the driving seat from behind and bitten the driver. The local manifestation developed immediately after bite, and investigations were normal except WBC is prolonged, and we had given him 27 vials of anti-snake venom. You can see the uh, tourniquet, how tight tourniquet they have tied on the hand. 65 years male with history of snake bite. He is diabetic also at the ankle joint, and while watering the plants, total anti-snake venom vials we had given 15 vials. WBC is incomplete up to 25 minutes. Local wound necrosis, debridement, and skin grafting is required. You can see subconjunctival hemorrhage after the Russell Swiper bite. This 19 years girl had a Russell Swiper bite on the left foot. She was admitted 2 hours after the bite. WBC was incomplete up to 45 minutes. She developed hematuria and upper GI bleeding also. Treating organ failure in snake bite is also very important. This 50 years female is admitted with history of snake bite on the left hand, tip of the middle finger. Swelling is massive up to shoulder joint. Blisters also develop. Clot at the fang mark is present. Ecchymosis, blebs, and gangrene. There is no issue of pain in abdomen. At primary health center, she received 10 vials of anti-snake venom, but her urine output is nil for more than 42 hours. So she was referred to our hospital and needed hemodialysis. Her total WBC count was 25,200, urea 155, serum creatinine 5.6. So we had given her another 20 vials. She required hemodialysis for 5 times. This is another important factor, Russell Swiper bite with neurotoxicity. There are many Russell Swipers who also develop neurotoxic signs and symptoms. This is 40 years male was admitted with a history of Russell Swiper bite on the forearm while sleeping on the floor at midnight. And there is pain and abdomen, all classical signs and symptoms. He developed bleeding, but additionally, he had a blurred vision, ptosis, difficulty in breathing, and difficulty in walking also. You can easily see ptosis on his forehead. He was treated with the anti-snake venom and other treatment. You can see his blood urea is also raised, 112, 120 milligram, and creatinine is also raised up to 5.80. You can see the classical ptosis. On day of admission, you can see the ptosis at 11:34 a.m., at 1:55 a.m., and at 6:45 p.m. also. Even after giving anti-snake venom, his ptosis remained for 5 to 6 days. There is a flaccid paralysis developed in such patients. He had also swelling and hematuria also developed. Then Russell Swiper bite with the cardiotoxicity. You can see this 40 years male with the history of Russell Swiper bite on the great toe. 15 minutes, 4 anti-snake venom at 4:35 p.m.
Sir, please unmute. Sir, please unmute.
Hello, can you hear me now?
Yes, sir.
I am getting some noises. Please request all of them to unmute.
So please, everybody, please keep your mic mute.
So WBCT, the whole blood clotting time is more than 2 hours. He was in hypertension and he developed arrhythmia, classical arrhythmia, ventricular arrhythmia you can see, and which are corrected after giving anti-snake venom. This is very classical. Immediately after giving anti-snake venom, his heart rhythm is regular. He was treated with the fluid challenge, IV fluid, Lasix, and mannitol, and hydration, that is forced alkaline diuresis. He developed severe anaphylaxis after the anti-snake venom. He also had a thrombocytopenia, required platelet transfusion. This is also an interesting case. This 55 years male who had a coronary angioplasty 2 years back before the bite, and he is already on the antiplatelets. He had a Russell Swiper bite. He was admitted in severe shock, hypotension, and respiratory distress. He was taken immediately on non-invasive ventilation. We usually prevent intubation in Russell Swiper bite patients because there are chances of traumatic bleeding in the trachea. His WBC is more than 1 hour. We had given him 20 vials of anti-snake venom. He was survived, but developed hemiparesis on the left side 3 weeks after the bite. His 2D echo showed thrombosis in the right atrium. This is also a very complicated case. 30 years male had given history of thumb prick to the private doctor. In the evening, he was taken to the private doctor. Hour after the history, he started complaining pain in abdomen, vomiting, and diagnosed as a acute appendicitis. Sonography also showed similar diagnosis. He was planned for appendectomy in the private hospital, but unfortunately, there is non-availability of anesthetists. So surgery was postponed till next day morning, but GC deteriorated and so transferred to our hospital early in the morning. When we catheterize, there is severe hematuria. You can see classical red mode. There is subconjunctival hemorrhage, melena, and hello, swelling all over the face. Is increased up to 51,700. His platelets are decreased up to 24,000, 19,000. Urea creatinine is also raised. He required hemodialysis, then 4 RDP transfusions, platelet transfusions, blood transfusions. He also had a left hemiparesis, convulsions, and all multiple complications. He required 4 fresh frozen plasma transfusions, blood transfusions, PCV, and 20 hemodialysis. This 65 years female had a history of Russell Swiper bites. She was very critical, admitted in hypotension. Sudden desaturation is there. She was unconscious, immediately intubated. ECG showed ischemic heart disease plus ventricular tachycardia. CKMB is raised. We had given her 20 vials of anti-snake venom. She also had a bronchial asthma. Her 2D echo showed LVEF 25% ejection fraction only, and left ventricular hypokinesia. Anterior wall. She has heart failure. There is severe leg sloughing and local necrosis developed. She also survived after the treatment. See, this is a classical case. 40 years male of history of snake bite at 5:30 a.m. in the morning while going to the toilet. He was admitted 2.5 hours after the bite, complaining of dizziness. He was drowsy, giddiness, throbbing pain, active bleeding at the bite site, swelling at the bite site after 1 hour. And he had also ptosis also. He was admitted in shock, BP 92, 65 millimeters of Hg. Then saturation is decreased. He was conscious and well oriented. In the investigations, his blood was not clotted for more than 1 hour. And swelling, tenderness up to anterior abdominal wall, hypotension, blisters appearing within 24 hours. You can see count is increased, urea creatinine is also raised. There is abdominal pain on day 3, tenderness, swelling up to abdominal wall and pelvis region. New blisters occurred. There is superficial necrosis at the bite site. He was stable, urea creatinine again raised. He was on antibiotics like Tazobac, meropenem. Urine output is decreased. Then he was referred to the civil hospital. WBCs are increased. We had given him 40 vials of anti-snake venom. He required given 2 FFPs post-alkaline diuresis. This is another case, 62 years male patient, admitted after 5 days of the bite while going to for toilet, and he has not recognized it as a bite, and he presented very late with the severe swelling, blisters, and local necrosis. He required antibiotics, higher antibiotics, and debridement twice and skin grafting also. We are able to save his limb, but he was totally neglected his history of swelling and pain at the bite site. This is a swiper bite with the ARF, 47 years old male with history of Brazil swiper bite. At the right foot, there is history of vomiting, headache, abdominal pain at the site of bite, hematuria. You can see WBC it is more than 45 minutes. Injection anti-snake venom 30 vials required. Antibiotics, urea and creatinine is also raised. And you can see severe hematuria. He required 18 hemodialysis settings. These amputations in case of Brazil swiper bite, we are able to prevent major amputations. There is no major limb amputation, but the finger and toe amputation we are unable to prevent because these capillaries are very small and necrosis occurs immediately after the bite. In case of cobra bite, swelling is localized, and in Brazil swiper bite, it is very severe swelling, rapidly progressive. Necrosis occurs in 33% of the patient of cobra bite and 41% of 21% in case of Brazil swiper bite. Debridement, 14% of the patient required debridement in cobra bite and 8% in Brazil swiper bite. Skin grafting, in Brazil swiper bite, 3% of the patients required skin grafting. Amputation, only 0.5% of the patients required amputation. This is the 0% mortality and 0% renal failure in Brazil's viper bite. We have presented this poster presentation in International Toxinology Conference at Oxford University, UK. Challenges in snake bite management, wound care and saving limbs. Dr. Mrs. Pallavi Rao presented this poster at International Toxinology course in Abu Dhabi. We have shown that we are able to save the limbs of the patient with the proper wound management. This is ICU management in our hospital and dialysis center. Now, Indian saw-scaled vipers, these are also common in our area. These bites are common. We are seeing many patients of Brazil swiper bite. Signs and symptoms are almost well. There is local symptoms like swelling and pain, which appear within few minutes of the bite. In very bad cases of swelling, they may extend up to the entire affected limb within 12 to 24 hours after the bite. Systemic symptoms are same: hemorrhage and coagulation defects, hematemesis, melena, hemoptysis, hematuria, epistaxis also occur and may lead to hypovolemic shock. There is oliguria or anuria. In some cases, hemodialysis may be required due to acute kidney failure. Treatment is same: antivenom therapy and intravenous hydration within hours after the bite, except that anti-snake dose is less than the Brazil swiper bite. This is a 57 years male with the history of snake bite at right leg medial side of the ankle joint. History of severe pain in abdomen, swelling. You can see blisters up to the thigh, swelling of the scrotum and the penis also occurred. Fang marks, clot at the fang marks, flames, gangrene. Where this patient has received anti-snake venom 8 vials of anti-snake venom at the rural hospital, and swelling, and there is anaphylaxis to anti-snake venom. Treatment: we have given additional 40 vials of anti-snake venom, antibiotics and IV fluids. Snake is also confirmed. This 50 years female is admitted with the history of snake bite to the medial side of the thigh while cutting the grass. You can see is admitted with a very severe shock, tachycardia, pulse rate is 135 per minute, BP is 60, systolic, peripheries are cold, fang marks were present, swelling, ecchymosis. There is respiratory depression. Saturation is dropped to 19. WBC is normal. We have started her with non-invasive ventilation anti-snake venom 10 vials 1 hour. But immediately after the tourniquet, her BP is dropped to 40 systolic. So sometimes tourniquet may be useful. We should not hurry to remove the tourniquet. We have treated her with shock management, injection steroids, dopamine, adrenaline, and humaxin, Dexa and IV fluids, and anti-snake venom antibiotics. This is also a case of Swastika viper bite. You can see local slow progressive edema, systemic signs are rare. Blood may be incoagulable, but systemic bleeding is not common. AKI is less common as compared to Russell's viper bite. Mortality is less. This is also Swastika viper bite. Admitted 72 hours after the bite. He was applying some Ayurvedic leaves, and then he developed hematuria, and then he came to our hospital. We had given him 25 vials of anti-snake venom, hydration therapy, and antibiotics. This is very interesting case. 20 years female patient with 5 months primipara. She was admitted in shock. 54 hours after the Russell's viper bite, she was taken to 5 different hospitals and traveled 550 kilometers of journey. And lastly, she was taken to the Mantrik from the government hospital because they were not happy at the government hospital due to some reasons. And then she was admitted to our hospital very shocked. We have treated her with shock management, blood transfusions. She became normal and delivered normally at the government hospital 2 months after the bite. She delivered a female child, which is also normal. This is a bamboo pit viper or green pipe pit viper. These cases are also common in our area, that is in Western Ghats. Bamboo pit vipers and green pit vipers are very common, but there is none of them is covered by Indian polyvalent antivenoms. So there is no need of giving anti-snake venom in a green pit viper or bamboo pit viper bites. Just remember, this is very important. There is local swelling, severe edema, and WBCT may be prolonged, but still you should not give any anti-snake venom. Treat these patients only with the antibiotic and swelling management, that is glycerin maximum dressing. Can see this green pit viper bite patients. This is the green pit viper. No anti-snake venom is required. This is also a case of green pit viper bite. You can see very huge swelling. Somebody must be thinking of giving anti-snake venom. WBCT is also prolonged for more than 1 hour. But only thing is that observe these patients carefully. No anti-snake venom, only painkillers, analgesics, anti-inflammatory drugs, and glycerin maxwell dressing and antibiotics. So investigations of Russell's viper bite, all routine investigations like hemogram, bleeding clotting profile, blood group cross-matching, LFTs, RFTs, then sodium, potassium electrolytes, serum fibrinogen, LDH, coagulation profile, ABG, ECG, 2D echo, X-ray chest, VG abdomen, CT, and MRI brain. But most important investigation is whole blood clotting time. We have to take 2 ml of blood in a plain glass tube and keep it 2 hours for unstirred for observation. If it is clotted after 20 minutes, then there is no need of giving anti-snake venom. And it is also diagnostic and helpful in management also to decide the dosage of anti-snake venom. If it is not coagulated, then diagnosis is definitely it is a vasculotoxic snake bite. Either it is Russell's viper bite or saw-scaled viper bite. So this is very important test, and it does not require any specifically trained person. You can do it at a bedside, very easily diagnostic. Snake venom detection kit. This is not available in our country. This is in Australia. There are 11 different venomous snakes in Australia, and they diagnose it with this diagnostic kit. They just take a swab from the bite site and put it in the test tube. There is some antigen antibody reaction, and color changes to the blue if there is no venomous snake bite, and they can diagnose particular snake. And it is not available in our country. So all other highly investigations, fibrinogen degradation product, D-dimer, fibrinogen, prothrombin time, all these investigations we are not doing. We are just doing a regular investigations with the whole blood clotting time. This is also important slide, diagnostic phase symptoms. This is a syndromic approach. You can see there is a severe pain and tissue damage after Russell's viper bite and Schwarzschild viper bite. Ptosis and neurological signs may be present in case of Russell's viper bite, but not in case of Schwarzschild viper bite. Hemostatic abnormalities, systemic bleeding in Russell's viper and Schwarzschild viper bite may be present. Renal complications in Russell's viper bite are more common. Response to neostigmine is present in cobra bite. Response to anti-snake venom, all these have response to anti-snake venom except green pit or bamboo pit viper. So this is very important diagnostic approach, symptomatic approach. So we must know about the diagnosis of snake bite from history. You can easily identify which snake has bitten, time and place of bite, activity at the time of bite, what he was doing farmer, examination at the site of the bite, identification of the species identified by the patient relative, or you can identify from pictures, photos, killed snake is brought or not identified. But there is no need to waste time in identifying the species of the snake. You can identify from the symptoms and systemic examination. Management, first aid and early and safe transportation is very important. You have to keep the patient in a clean area and we have to lie down him. Legs should be elevated, and if patient is unconscious, then while transporting, keep him in a left lateral position. So there is chances of aspiration are less. Specific management, anti-snake venom is the only antidote for snake bite management. We are going to discuss doses in next slides. Management of cardiac complications like arrhythmia and hypotension, management of acute kidney injury, management of local site edema, necrosis and gangrene, and management of conjunction coagulation. These are important points in management of any snake bite. So treatment protocol, like any other emergency, airway, breathing and circulation, identification of snake, don't waste time. Rule of 24 hours is very important. Any unknown bite or any snake bite, you must be observed for 24 hours. Bite marks, it is sometimes very difficult to identify snake initially from the bite marks. There is traditional medicines. You must avoid traditional medicines. Time of bite is very important in the case of diagnosis of the snake bite. Treatment protocol is pain management, paracetamol, and tramadol. Handling tourniquets, as I told, is very important point. Don't hurry to remove the tourniquet. There is research, and tourniquets may or may not be useful, but if tight, don't hurry to remove unless start IV or anti-snake venom. Then anti-venom treatment. It is very important. Anti-venom is the only specific antidote to the snake venom. The most important decision in the management of snake bite victim is whether or not to give anti-venom. Many times it is given when it is not indicated or given in less amount when indicated. So it is very important. The doses and indication are most important. Anti-venom should be given only to the patients in whom its benefits are considered likely to exceed its risk. Since antivenom is relatively costly and often in limited supply, it should not be used indiscriminately. The risk of reaction should always be taken into the consideration. So, if doses hemotoxic bite, such as the Russell's viper bite or Schwarzschild viper bite, you should give initial 10 vials within first 1 hour, and depending on whole blood clotting time, you additional vials, maximum 40 to 45 vials are required. So there is no contraindication for anti snake venom in venomous bite. Adrenaline prophylaxis is preferred. Preferred 0.25 milligram of adrenaline subcutaneously may be given before starting anti-snake venom. It is usually polyvalent, prepared from big four venomous snakes. There is no need of test dose. Many doctors waste in testing anti-snake venom. It should be diluted in normal saline. No intramuscular anti-snake venom should be given. Do not use at the site of bite. Close monitoring of vital signs and symptoms is very important immediately after starting anti-snake venom till it is over. Anti-snake venom neutralizes circulating venom. Be aware of adjuvant treatment. Indications: local, there is rapidly progressive swelling, more than one joint, swelling after bite on digits, local bleeding, necrosis, systemic bleeding, development of enlarged tender lymph nodes. You must start anti-snake venom. Systemic signs and symptoms: neuroparalysis, cardiovascular abnormalities like hypotension, shock, arrhythmia, bleeding gums, brown urine, hematemesis, abdominal pain, backache, vomiting. Then anaphylaxis, all of us know that there is early anaphylactic reactions, pyrogenic reactions within 1 to 2 hours after treatment, and late serum sickness reaction. Early anaphylactic reactions must be observed and treated very carefully within 10 to 180 minutes occurs. There is mild, severe itch, urticaria, dry cough, fever, nausea, vomiting, abdominal colic, and diarrhea, tachycardia, and hypotension. Severe life-threatening reactions may occur: hypotension and severe bronchospasm and angioneurotic edema. Treatment is injection adrenaline 0.5 ml intramuscularly, IV fluids, oxygen, antihistaminics, and steroids. Adrenaline is the only treatment for severe anaphylaxis and should be kept ready bedside immediately after starting anti-snake venom. Management of conjunctive coagulopathy, that is fibrinogen deficiency or multifactorial. FFP is indicated only in case of severe bleeding. If there is active bleeding, then and then only give FFP. Dose is 15 ml per kg body weight. Cryoprecipitates one bag. Then heparin is not recommended. Platelet transfusion, only if platelets are below 30,000 or there is active bleeding, then do platelets. Otherwise, don't hurry to give platelet transfusions. Adverse reactions of platelet transfusions are anaphylaxis, pyrogenic reaction, circulatory overload. Post-alkaline alkaline diuresis is very important in the early management of oliviric phase of Russell Swiper bite. If it is given, many patients start getting opening up and kidneys are open and there is no need of diuresis. But it should be started as early as diagnosis of AKI, oliviria is there. So injection furosemide 40 milligram IV stat followed by IV normal saline 500 ml, injection IV ringer lactate, and then injection soda bicarb 20 ml, 5% dextrose plus 10 ml Kesol in 90 minutes, mannitol 150 ml in 20 minutes. It is beneficial only in case of olivuric phase. So we have to monitor central venous line before starting this post-alkaline diuresis. Total time of the cycle is 150 minutes. Total fluid given into the patient is 1700 ml and expected urine out should be 3 ml per minute. That is 450 ml per hour. If it is not there, then stop FAD and patient may require dialysis. Capillary leak syndrome. Many patients, those who receive inadequate dose of anti-snake venom or no anti-snake venom after Russell Swiper bite, they develop capillary leak syndrome. There is dysfunction of vascular endothelium, leakage of intravascular fluid depletion. There is hypotension and impaired delivery of oxygen to the tissue. Hypotension, chemosis, periorbital edema, parotid swelling, and generalized anasarca is there. Hemoconcentration, hypotension develops and acute kidney injuries also develop. Crisis manifests by abdominal pain and vertigo followed by rapidly by severe shock. Leukotriene B4 plays a central role in case of pathophysiology of capillary leak syndrome. And there is very high mortality if once patient develop capillary leak syndrome. This is also a very important flow chart for the management of the snake bite. We have discussed all these points. You can see wound management. 90% of the proteins are present in Russell Swiper bite. 80 to 90% are enzymes, proteinase, endoproteinase, exoproteinases, phospholipids, diesterase, myotoxins, cytotoxins, PLA2s, SP, small volume molecular proteins, acetylcholinesterase, hyaluronidase, etc. And wound management challenges are due to poor or dangerous first aid, tight tourniquets, snake oral flora, environment factors, environmental incision on the bite site. So wound point management, we have to give relief for the pain. with the paracetamol or tramadol. No non-steroid anti-inflammatory drugs, NSAIDs, can cause bleeding. Prophylaxis with broad-spectrum antibiotics, glycerin, limb elevation, surgical intervention, vac therapy, skin grafting, amputations, application of back slabs, fasciotomy, rehabilitation, injection KT. Challenges: takes long time for healing, crippling loss of income, debt, mental and physical health, reduces quality of the life. To reduce less use of expensive antivenom, reduction of hospital stay, cost, morbidity, and morbidity. To overcome the challenges, strong need of selective small molecular antidote that blocks SPLA2s. Broad neutralizing antivenom is required. Unknown bite or suspected bite, you must observe any patient for 24 hours. In some patients, signs and symptoms develop 5 to 6 hours or even after 12 hours after the bite. Confirmed bite, if there is confirmed bite, then proper history should be taken. Signs and symptoms of innovation should be observed. Hematotoxicity also may be associated with neurotoxicity. WBC is very diagnostic test, important diagnostic test. You should watch on renal function test, liver function test. Injection anti-snake venom should be given according to the WBCT, which is repeated every 6 hours after the bite. Use non-invasive ventilation if SpO2 is not maintained in case of Russell Swiper bite. Never hurry to intubate the patient. If there are clotting abnormalities, dialysis is done if required. Platelet or blood transfusions are given. Conservative treatment. Proper wound care, debridement, skin grafting, contractures, release surgery if necessary. So all these are the survived snake bite victims. Thank you.
Thank you, sir. So
Thank you, sir.
it's open for discussion. If you have
Any
any query,
questions?
ask directly to sir. There is one message chat box that
Chat box. Chat box.
please show Russell Viper mechanism. So
What is the mechanism? Hello.
sir, can we show Russell Viper
Yes,
mechanism?
mechanism of action.
Yeah.
What they want?
Uh,
Yes, it's like
yeah. Dr. Aman, are you there? You can directly ask
Yes.
your question to sir. Okay. So, sir, my one request is that please guide us about do's and don'ts in snake bite.
Okay. Do's and don'ts. So initially, there are many. I'll share that slide.
Okay, sir.
Important thing that patients after bite they start running. So you just assure the patient and ask him to keep calm and quiet. Lay and there is no hurry to cut at the site of the bite with the Swiper bite. So in case of presence Swiper bite, never give cut at the bite site, and there are chances of developing tetanus also later on. And limb should be kept below the level of the heart, and he should be transported to the hospital very carefully immediately after the bite. Where if he is transported on the motorcycle, the patient should be held in between two persons, and care should be taken of his limbs. His limbs should be kept on the footsteps. Otherwise, many times there are chances of injury to the limbs, and there is active bleeding at the site of the bite. And when he is transported in the jeep or the ambulance, he should be always kept on the left lateral side to prevent the aspiration. And while going to the hospital, you should inform the concerned doctor that we are bringing the patient with the ready with the all essential things like intubation, and if you should inquire whether there is doctor is available there or not, and anti-snake venom is also available or not. So these are very important points in case of any snake bite. So you should not be first important thing is do it right. You should reassure the patient, immobilize him, bitten part should be kept below heart level, and go to the hospital immediately and inform the doctor systemic symptoms and ptosis if he is developing. So sometimes there is no even second or minute is important for the intubation of the patient. And many patients are reaching to our hospital in cardiorespiratory arrest. So we have good communication with the doctors and relatives also, and they are informing us immediately after the bite. Don't give cuts. All primary aids we are taught, learn in the primary schools, they are wrong. Do not use cold compresses or ice pack. Do not raise area of the bite above the victim's heart. Do not attempt to suck the bite site venom by mouth of another person. Do not use a pump suction device. Do not use tight arterial tourniquets. There is risk of ischemia, necrosis, and loss of limb. We have shown this in picture. This is a very smart bandage. This should be used instead of tourniquets. So this is the primary aid. All of us know tourniquet should not be very tight. Then this is a smart bandage. I think this is okay.
Okay, sir. Thank you. So, if you have any query, again, I request to all, if you have any query, you can ask directly to sir.
Thank you very much, sir.
Photo.
So, again, one request that please guide us about tourniquet application.
Hello. Tourniquet
guide.
application.
Tourniquet.
This is a just like crepe bandage or a smart bandage, and we should apply it in the similar pressure from the bite side to the shoulder joint. If it bite to the fingers, then apply it from the fingers to the shoulder and give a equal pressure. And if it is to the toes, then you apply from the toes to the thigh. This is a smart bandage. So this is a smart bandage. We have to give a pressure. This you can see rectangle on the bandage. This is international code. You have to give stretch, and it should become a square. Till that you have to stretch. Then it creates a pressure equal to 70 millimeters of Hg, and then you have to apply this pressure.
Computer section ला सरांची स्क्रीन एनलार्ज करता का ते बँडेज दिसेल मग सगळ्यांना.
Can you see? Can you see rectangles?
Yes, sir.
This is international code, and you have to stretch bandage, and now you can see square on the bandage. So that much pressure you have to apply while applying the bandage to the hand or limb. 50 millimeters of Hg, and they say that there is a delay in absorption of venom up to 12 hours. So even if there is a delay in getting patient transportation or admitted to the hospital, there is a less venom absorption due to this, and chances of this necrosis and gangrene are also reduced. So this is very important. This is under research, but it is better than tourniquets. Okay.
Yes, sir. Thank you. So YouTube link is available there. So I will give YouTube link for that. There is one query, ma'am, ही PDF मिळेल का? तर याची YouTube लिंक आहे. रेकॉर्डेड हे कंप्लीट लेक्चर अवेलेबल आहे. ते मी तुम्हाला सगळ्यांना प्रोव्हाइड करेल. ऍक्च्युली हे पावसाळ्याचे दिवस तोंडावर आहेत आणि आता सगळ्या खूप साऱ्या सर्पदंशाच्या केसेस आपल्या क्लिनिक्स मध्ये येणार आहेत आणि त्याच दृष्टीने आपण हे लेक्चर अरेंज केलं होतं आणि त्याला तुम्ही सगळ्यांनी भरभरून रिस्पॉन्स दिला. राईट डिसिजन ऑन राईट टाइम इज अ की ऑफ सक्सेस इन स्नेक बाइट्स ऑल्सो. Left lateral position to avoid aspiration, management of cardiac complication, ABC management, then anti-snake venom, 10 to 40 vials, never refer before admission of 10 vials. Then, so thank you so much, sir, for your valuable time and wonderful presentation. We salute your work actually. So, thank you.
Thank you, madam.
Thank you.
Thank you. करू.
So can we stop this sharing? If there are no doubts, we are going to stop the live streaming.
हॅलो, हा कारले मॅडम.
Yes, sir.
हा, डॉक्टर सचिन कुमार पाटील, हेड ऑफ सर कॉलेज.
Namaste, sir.
हा, ते मग आपल्याला पीपीटी वर सगळ्या मिळाल्यात बरं होईल सगळ्यांना, कारण खूप महत्वाचे प्रोटोकॉल्स आहे ते. तर आपण याचे
आपण PPTs नाही देणार आहोत. आपण डायरेक्ट जे आपला रेकॉर्डेड व्हिडिओ देणार आहोत सगळ्यांना.
आपण चार्ट्स असताना ट्रीटमेंट प्रोटोकॉल मॅनेजमेंट असताना आता आपण चार्ट्स बनवू शकतो. तंत्र डिपार्टमेंट किंवा मेडिसिन डिपार्टमेंटला आयसीयू ला वगैरे ते डोसेस वगैरे खूप महत्वाचं आहे, म्हणून त्या दृष्टीने पीपीटी मिळालं तर बरं होईल.
ओके, ठीक.
थँक्यू मॅडम, थँक्यू व्हेरी मच.
थँक्यू. So thank you. We are stopping the live streaming now.
Okay.